We're at a really, really challenging phase of this pandemic. I've said before, the second wave, if we are going to call it, is very different to the first wave that we've gone through for a whole bunch of reasons. The population's affected, the fact that we're all rather fatigued, we're all a bit inured to the numbers. If we'd had a number of, close to 500 in March or April, we would have been staying in our bedrooms and not leaving the house. But some of the challenges in this phase as well relate to the complex environments where cases are occurring, that issue of insecure work. So I think it is absolutely challenging at the moment. The R number has come down from 1.5 to more like 1.2. Other models show that it might be even lower. My suspicion is it's still above 1, and we can't necessarily expect numbers to go down. I think that will be an even greater challenge in days ahead. That means that we're going to look at 500, 600 cases per day. I absolutely don't want us to go there. So we have to reinforce the things that we know will make a difference. And that is the very simple principles of isolation and quarantine. So that issue of getting tested very early in your illness, you're actually most infectious in the first couple of days of your illness. So the very beginning of that runny nose or sore throat or cough or low-grade fever is when you're most infectious. You're probably not that infectious after 7 days. So getting tested very early on and isolating right at the beginning is a really key action. And I think they're things that are not being done so well through this wave as for our first wave. So I think we're in pretty tough times if we're going to turn this around, but we do know what works. And I know that Victorians have stepped up in so many ways, including all the masks that I see now, including the fact that a lot of mobility data suggests that people are absolutely staying home, but there are lots of people who are still moving about, and the most critical ones to reach are those who've got those early symptoms, who need to be at home getting that test and waiting for that result.
Where's the information from? Saying they're not isolating while they're waiting for a test, is that from the app or is it from the interview?
No, that happens through the interview process. So everyone is asked, when did you first develop symptoms? When did you get your test? How many people might you list as close contacts while you're infectious? And so that figure of number of close contacts within and outside the family and the number of so-called exposure days, so time that you're infectious and out in the community, are those key metrics that we follow. The number of close contacts is decreasing. That's a sign that people are staying more isolated. But the fact that there's still 3 exposure days per person is super challenging, because that means there are 3 days of potential transmission to other people.
And has there been conflicting advice from DHHS about what to do? I've seen a form from the 17th of May 2020 that sort of says, what should I do while I'm waiting for the test result? And the advice from the government and the health authorities, if you are feeling well and you do not have any coronavirus symptoms, you can continue to work and go about your usual activities. Well, has that contributed to the situation that we're now in?
No, I don't think so. So people who are going to our testing stations now should be symptomatic. There are some very specific settings where people without symptoms are getting tested, but you are 40, 50, 60 times more likely to have coronavirus when you're getting a test with symptoms. There are some settings where we know aged care, meat works, other explosive outbreaks where we know we need to test people who are asymptomatic, because they are very likely to have been exposed and therefore be in the pre-symptomatic phase. So we can pick people up before they develop symptoms. But broad asymptomatic testing in the community does not pick up cases. When we've done our blitz, there have been half a dozen cases out of tens and tens of thousands. So they are not the individuals who are any more at risk than any other asymptomatic individual out there.
One of the biggest weapons we obviously have in fighting this pandemic is contact tracing. We know that there is a significant backlog. Parts of Victoria have been in lockdown for almost 3 weeks now. I guess, how do you, or is there an ability to bolster your contact tracing team, and how would you go about doing that?
So there's no specific need to bolster our contact tracing team. It is huge, over 2,000. The bottleneck is not in outbound calls. We could get through 1,000 cases if we had 1,000 cases today. Health Direct staff who are now onboarded are numbering their hundreds. They can each do 5, 10 interviews. So we can do a lot of interviews. The complexity is in all of these settings where outbreaks occur and managing all of the difficult circumstances of those outbreak settings. So that's an ongoing challenge. You can throw people at it, and we've got people working on it, but the real challenge is not to have those outbreaks occur in the first place. And the key element there is to isolate at the first sign or symptoms of coronavirus. For example, in aged care, we've got as many staff who've become positive with coronavirus as residents. That is a huge challenge because every one of those staff members is potentially passing it on to residents, and the residents are the most vulnerable, and that leads to the outbreaks that we're seeing.
So how long is too long to get a call? Because there's a lot of anecdotes of I waited 4, 5, 6, 7 days, kid in my class, a kid in my kid's class, we haven't been called. How long's too long?
We would absolutely aim from the time that we've got receipt of a positive result to phone people in the first 24 hours. What people sometimes do not recognise is that they will be notified directly by the pathology provider that they're positive. We only know about people when we have received that result in the department. That doesn't necessarily happen at the same time. So when a medical practitioner calls us, then we know. When a pathology service passes on that result, then we know. But that path slip does not say this is someone in a sensitive setting. This is, someone who's at a workplace or in an educational setting or at a meatworks. If we're doing an outbreak response, we'll know that and we'll compartmentalise those results and we'll get them directly. But for people who are going to drive-through testing sites, we don't know the settings that they're in. And so it is important, if you're getting that result yourself, to do the right thing, isolating immediately, as we said yesterday, to list the close contacts that you know, to have their details down. And so when you get that call for an interview, you can provide all of those results. But our metrics are absolutely to contact people in that first 24 hours.
So it's one of the issues pathology providers not providing positive or negative results to you sooner?
So there is an automated process for individuals to get that SMS notification. For pathology providers, they will have a bulk number of thousands of negative tests and a number of positive tests that come through. That is not necessarily as timely as for the individual being notified. But again, I don't think that's problematic if someone who receives their result does the right thing. The other thing we know is that for maybe a third of the people we're following up on a daily basis, they're not picking up the phone. So if you're getting that unidentified number, that may well be the Department of Health and Human Services. If you've got a result and you know you're positive, we are trying to contact you. So please answer the phone. We will continue to try and contact people, but sometimes if people say they haven't been contacted, it's because they haven't picked up the phone because they don't recognise the number or because it's a private number that's coming up. We'll work on other ways to engage with those individuals, including prompting for a door knock. But I would urge everyone, especially if they're aware that they're a positive case, if you're getting a phone call, it may well be the department trying to work out all of your close contacts, getting them captured in the system, and then getting an automated message and following up with phone calls for all of those individuals.
Are the delays acceptable? Are you okay with the delays, or do you need to make it?
No one would be happy with a delay in terms of identifying close contacts. So again, if people can pick up the phone, we know that we'll get those details earlier and we can follow up with those close contacts. If people already know that they are a case, they can go through the process of detailing all of those close contacts and indeed contacting them if they're comfortable and confident in doing so.
If you have a positive case and haven't answered the phone, what is the time between someone going to their door, between an unanswered phone call and someone turning up on their doorstep?
We're going through a process now to try and refine exactly how we'll do that. We've got, as you know, additional ADF personnel who might even assist in that process, but a follow-up phone call from our call centres is the most appropriate one to just keep trying people, but we are working through a process now where we would aim for a knock on the door on the same day for that very reason, bring down the exposure days that someone might be infectious.
Protocol too little, too late, because we've had triple-digit growth for the last 3 weeks.
We have always tried to contact people at the earliest possible time, but we are looking at where particular issues arise and trying to address them as we see where the contribution to transmission might occur. And so putting the word out that people absolutely have to isolate when symptomatic is not a new message, but we're focusing on the fact that it's not been sufficiently addressed and we need to keep hammering that home. We'll do that for any other message that we think is relevant to transmission.
Just on high-risk settings, given what you've said, is there a need for a directive to stop people working across multiple high-risk settings, be that meatworks, be that aged care providers? Is there a way you can do that to try to minimise the spread in those settings?
Yeah, essentially not a directive, because there are always reasonable excuses, or there are practical impediments to stop that fully, and they will be very particular to a setting or an industry. But the WorkSafe inspections and the WorkSafe checks on businesses and the general policy direction that we're providing to all workplaces is absolutely to minimise your movements across any of the settings that might be part of that workplace. So that is an important feature. There are some industries, some settings where it's practically impossible, but we want it minimised to the fullest extent possible. And as you know, we've worked with the Commonwealth on aged care and really minimising the movement of people between facilities.
Do you know what the numbers are on where people are catching it? Like, is it 40% work, 30% home and 30% you don't know? Do you know what breakdown?
We know that for outbreak settings that there's a significant contribution in aged care, in healthcare, in those large indoor settings and in large apartment settings. So they're significant drivers, but there are a number of other workplaces that will have transmission occurring.
So this is mostly work?
Mostly work or health or aged care.
Sorry,
But we can't always determine exactly where someone's gotten it from. We do know that there's a significant reduction in household to household transmission. That's absolutely a result of the restrictions that have been in place.
Just to go back to the question around New Zealand style lockdown, considering the vast majority of the cases are through workplace transmission, is there a need to impose stricter lockdown measures?
So everything is under consideration, but again, to go to a particular model of lockdown that worked for one country at one point in time is not the solution. We have to understand what the dynamics of transmission are in Victoria at this point in time. It may well be that it's an awful impost on the economy and on people's lives with no material benefit if we go to a New Zealand style lockdown. We have to understand where the transmission's occurring and what measures will be most effective in reducing it.
Have you got any stats on... Oh, I've got 2 extra puts.
Sorry, I just wanted to clarify the nature of the transmission we have going on at the moment. Would a New Zealand style lockdown be enough to, suppress the numbers even more, or would it be unnecessary because people are still going to have to go to work?
Well, I certainly wouldn't even assume that a New Zealand style lockdown will address the issues that we have. Obviously, people were very constrained during that 4-week period in New Zealand, but New Zealand didn't have significant community transmission. Again, they were identifying the close contacts of international travellers, and it was a much, much more straightforward contact tracing process, as it was in Victoria through the first phase. So I wouldn't make assumptions that harder, more constrained lockdown is necessarily the way to go. We have to be targeted in terms of seeing where the issues are and addressing them directly.